When a person is positive for the hepatitis B surface antigen, we test the severity of liver disease using non-invasive tests such as APRI or transient elastography. Then we check the ALT and HBV DNA levels. Then we ask for medical history, screening for presence of co-infections, example HIV, HDV or HCV, comorbidities, example diabetes, steatotic liver disease, immune suppression, example long-term steroids, transplant, extrahepatic manifestations, example glomerulonephritis, vasculitis, or family history of liver cancer or cirrhosis. Then we take general care measures. 1. Counseling of lifestyle, example alcohol consumption, diet and physical activity. 2. Preparation for starting treatment, example adherence support, risk factors for renal dysfunction, and baseline renal function. 3. Preventive measures, example hepatitis B surface antigen screening of family and household members, and sexual contacts with HPV vaccination of those negative. Treatment is recommended for all adults and adolescents aged above 12 years old with chronic hepatitis, including pregnant women and girls and non-pregnant women of reproductive age with 1. Evidence of significant fibrosis based on an APRI score of above 0.5 or transient elastography value of above 7 kilopascal, or evidence of cirrhosis based on clinical criteria or an APRI score of above 1 or transient elastography value of above 12.5 kilopascal regardless of HBV DNA or ALT levels, or 2. HBV DNA above 2000 IU per ml and an ALT level above the upper limit of normal ULN, 30 unit per liter for men and boys and 19 unit per liter for women and girls. For adolescents, this should be based on ALT higher than ULN on at least 2 occasions in a 6 to 12 month period. Or 3. Presence of co-infection such as HIV, hepatitis D or hepatitis C, family history of liver cancer or cirrhosis, immune suppression such as long-term steroids, solid organ or stem cell transplant, comorbidities such as diabetes or metabolic dysfunction associated steatotic liver disease, or extrahepatic manifestations such as glomerulonephritis or vasculitis regardless of the APRI score or HBV DNA or ALT levels. Or 4. In the absence of access to an HBV DNA assay, persistently abnormal ALT levels defined as 2 ALT values above the ULN at unspecified intervals during a 6 to 12 month period, regardless of APRI score. Let's talk about existing and maintained recommendations according to the WHO for the treatment. Nucleoside analogues with a low genetic barrier to resistance, lamivudine, adifovir, or telbivudine can lead to drug resistance and are not recommended. For the updated recommendations, all adults, adolescents, and children 2 years or older for whom antiviral therapy is indicated, the nucleoside analogues that have a high genetic barrier to drug resistance, tenofovir, disoproxil fumarate (TDF), or entecavir (ETV) are recommended as preferred regimens. TDF plus lamivudine 3TC or TDF plus emtricitabine FTC are recommended as alternative regimens where TDF monotherapy is not available. For the new recommendation, entecavir ETV or tenofovir alafenamide fumarate TAF, if available, are recommended for people with established osteoporosis and or impaired kidney function, and for children, ETV for those aged 2 years or older, or adolescents, TAF for those aged 12 years or older as alternative regimen for whom antiviral therapy is indicated. TAF is not recommended if the estimated glomerular function rate is below 15 ml per minute. Note, for HIV and HBV co-infection, Dolutegravir (DTG) in combination with a nucleoside reverse transcriptase inhibitor (NRTI) backbone is the preferred first-line drug regimen for adults, adolescents, and children living with HIV initiating ART, including those with HIV and HBV co-infection. Efavirenz EFV at low dose 400 mg is an alternative to DTG for adults and adolescents. Knowing the hepatitis B surface antigen status of people living with HIV is important before initiating ART or switching regimens and before initiating PrEP. Current ART guidelines recommend using TDF in combination with 3TC or FTC as the preferred NRTI backbone option for most situations in HIV management, including HIV and HBV co-infection. TDF, TAF, 3TC, and FTC are all active against both HIV and HBV. TAF could be an alternative to TTF in specific clinical situations for people co-infected with HIV and HBV, especially if renal or bone problems are a concern, and for adolescents. If neither TDF or TAF can be safely used, the alternative recommended hepatitis B therapy is ETV in addition to a fully suppressive antiretroviral drug regimen (ARV). The nucleoside analog combination should be retained if the ARV drug regimen is changed because of failure to suppress HIV viral loads. ARV drug regimens that do not include TDF, ETV, or TAF are not appropriate for people co-infected with HBV and HIV. Now let's talk about the recommendations for pregnant and women and infants. Existing and maintained recommendations according to the 2017 Strategic Advisory Group of Experts regarding immunization are the following. All infants should receive their first dose of hepatitis B vaccine as soon as possible after birth, preferable within 24 hours. Delivery of hepatitis B vaccine within 24 hours of birth should be a performance indicator for all immunization programs, and reporting and monitoring systems should be strengthened to improve the quality of data on the birth dose. The birth dose should be followed by 2 or 3 additional doses to complete the primary immunization series. Now for the existing and maintained recommendation according to the 2019 guidelines on HIV testing. For hepatitis B surface antigen testing among pregnant women and adolescent girls, all pregnant women should be tested for HIV, syphilis, and hepatitis B surface antigen at least once and as early as possible during their pregnancy. For the updated recommendation according to the 2020 guidelines on antiviral prophylaxis, for antiviral prophylaxis among pregnant women and adolescent girls in settings where HBV DNA or hepatitis B E antigen testing is available, prophylaxis with tenofovir disoproxil fumarate (TDF) is recommended for all HBV positive pregnant women with HBV DNA equal to or above 200,000 international unit per ml, or positive hepatitis B envelope antigen, preferably from the second trimester of pregnancy until at least delivery or completion of the infant HBV vaccination series to prevent the mother-to-child transmission (MTCT) of HBV. For a new recommendation for antiviral prophylaxis among pregnant women and adolescent girls, in settings where neither HBV DNA nor hepatitis B E antigen testing is available, prophylaxis with tenofovir disoproxil fumarate (TDF) for all HBV positive pregnant women may be considered, preferably from the second trimester of pregnancy until at least delivery or completion of the infant HBV vaccination series to prevent MTCT of HBV. All interventions should be given in addition to at least 3 doses of hepatitis B vaccination for all infants, including a timely birth dose. Note, All pregnant women and girls of reproductive age should be assessed first for eligibility for long-term treatment for their own health. For women and adolescent girls of childbearing age planning additional pregnancies, TDF prophylaxis can also be maintained after planning additional pregnancies, after delivering and during subsequent pregnancies, according to women's choice. The use of the B antigen recommendation represents an additional option for determining eligibility, but hepatitis B antigen RDTs have poor diagnostic performance, which limits their routine use in low and middle income countries. TAF may be considered for people including pregnant women with impaired kidney function and or osteoporosis, but is not yet approved for hepatitis B treatment in pregnancy. TAF is not recommended if the estimated glomerular function rate is below 15 ml per minute.